men's health, fertility specifically, and a lot more on this episode of All Things Women's Health. I'm an obstetrician gynecologist of more than 30 years. I'm a husband, I'm a father, I'm a grandfather, I'm a business owner, I'm a Catholic, I'm all kinds of things. But right now, I'm your guide as we talk about all things women's health, from menstrual problems to migraines, mammograms to menopause, homeschool curriculum to personal trainers. It doesn't matter. If it affects women and their health, it's on our agenda. And our agenda today is men's health, or maybe men's fertility more specifically. I can't think of a topic that I deal with that creates more confusion and we combat more mythology than this one. So I'm incredibly excited to have a true expert join me on the podcast today, Dr. Jim Dupree. Dr. Dupree is a urologist. He's going to tell you a lot more about that at a small place north of here called the University of Michigan in Ann Arbor, Michigan, where he is a professor of urology there. Jim, welcome to the podcast.
Chris, thanks so much for having me. It's an honor and a pleasure to get to join you today.
Oh, thank you. I'm sure when people hear that we're talking about men, they're just going to flock to the show. I'm just sure of it.
I hope so. It's half the equation most of the time, so it's an important part of the story.
Exactly. So, maybe before we get into sort of the meat of our topic, why don't you tell listeners a little bit about you and sort of your professional background and how you sort of got to be sitting where you are?
Yeah, happy to. Thanks. So again, I'm Jim Dupree. I'm a urologist at the University of Michigan. Specifically, I'm what most of us call a reproductive urologist. So within the broad field of urology, I am the type of urologist that really specializes in male fertility, sort of the male reproductive organs, the male reproductive system, and men trying to build their families. How I got here, I did my medical school and residency training at Northwestern. That's where I learned just to be a broad urologist in general. Then when I went on to do a fellowship specifically in male reproductive medicine and surgery, I did that down at Baylor College of Medicine for a year. And then I was very lucky to be able to find a position here in Ann Arbor at the University of Michigan. I am a husband and a father as well. And she wasn't my wife at the time, but my now wife is from Michigan and went to undergraduate, got her nursing degree here from the University of Michigan. And so I was very lucky and happy to end up here. And I've been here for 11 years now.
Wow. Now, I'm sure you're used to people asking you this question. They ask me questions like this all the time. But, as you're ending your urology training, you're probably excited and ready to get out and start working. And you didn't. You took additional training in male fertility, as you point out. Do you remember that decision and what it looked like, what drew you to specifically fertility and not, say, urological cancers or things like that?
Yeah, it's a great question. So I think many of us in life have been very lucky to have somewhat happenstance relationships that we're able to build with really important mentors in our lives.
Oh, sure.
Early on in my residency training, I got to do some surgeries with the reproductive urologist at Northwestern. His name is Dr. Bob Brannigan. And I realized from working with him pretty early on in my residency that I was very drawn to the conversations that happen in a fertility clinic setting. I think in terms of things that we can do as doctors to help patients. My father had prostate cancer. I'm very, very grateful for the urologic oncologist that treated and have cured him of that prostate cancer. And I think that another amazing thing that we can do as doctors is help people build their families. And I realized early on that I had this really incredible opportunity within the field of urology to get to do that, to get to meet with men and their partners and help them with what's often a very important and very stressful time in their lives, is building a family. I was also really drawn to the surgeries. The surgeries that we do are very delicate. They're both on delicate parts of the body.
Sure.
And then also technically they are very precise surgeries. And I learned early on that I think I'm good at that. And I really like it. And those were the things that drew me to this field.
Wow. Yeah, it's, I had this sort of picture in my mind when you were talking that, usually the husband and the wife are sitting in front of me like they are with you. Yeah. And if ever, if I pivot and start talking about the husband as a potential participant in the fertility challenge, the whole equation changes. We men, we don't always like to think that maybe there's something that we are contributing or not contributing that we should be. But yeah, there's certainly a whole psychology that goes into trying to help men understand that they may in fact be contributing to the problem, isn't it?
There is, absolutely. And I, probably like you, see all types of different perspectives among the patients that I take care of. Some
Yeah.
who are really, frankly, they're excited and happy to be there. Others, admittedly, are more reluctant. And I understand why they may be reluctant. It can be a intimidating or uncomfortable topic to discuss and bring up.
Yeah.
I think maybe that's a little bit why I was drawn to it as well. I think I enjoy having what can be difficult conversations at times with patients and
Yeah.
trying to find a way to hopefully set them at ease.
Wow.
I think what's really fascinating is that the research is pretty clear about when a couple is having trouble getting pregnant and having a child, about half the time the male partner's health is contributing in whole or in part to their trouble getting pregnant.
Yeah, what an important statistic. I mean, you just can't drive that home enough. A lot of times I'll say to the couple, now we need to think about you, and I'll look to the husband and I'll think, well, what is it about us that makes you think it's me? And I'll say, nothing, just the numbers. I'm just playing the numbers. Half of the time I'll be right.
Yeah.
Yeah.
And you think that to make a baby, it takes one egg and one sperm, 50%, 50%. And so it makes sense that, the male partner's health matters as well.
Yeah. Well, I mean, if you think globally, you talk to men every single day about fertility. What are the common challenges that you see day in and day out when it comes to men's fertility?
Yeah. So I think I broadly think about that in a couple categories. And so one challenge that we encounter is a man with a low sperm count.
Yeah.
And that is, lower than average numbers of sperm, assuming that kind of average numbers of sperm is usually what helps part of what helps a couple conceive. And we can talk, if you want, about reasons why mine might have a low sperm count, but that's part of what, the categories that we see.
Sure.
Sometimes also part of it is admittedly sexual health concerns, right?
Yeah.
So to conceive with intercourse, there are times, and it's actually more normal than probably anyone would expect, that a man is having trouble with erections or trouble with orgasms, trouble with ejaculation. And so that's kind of another category that's not so much sperm directly related, but still part of the process of helping the sperm get to where they need to be to meet the egg.
Yeah.
And so that's another set of conversations that we'll often have in our office.
So count, I mean, I think most men, when we say we're going to get a semen analysis, they think sperm count. But, speak to the other parameters that we look at and things that you see there commonly.
So I think the two most important parameters are the number of sperm and the movement of those sperm.
Sure.
If we think about sort of the biology of how most children are conceived, there need to be a sufficient number of sperm that have the ability to swim through the cervix, through the uterus, and into the fallopian tubes to find and fertilize the egg. And so those are the main two things that we look at. There are other things we look at as well. We look at sort of the volume of the ejaculate just to make sure that there aren't things causing some of the ejaculate to be going backwards into the bladder, for example. We look at times for markers of infection. That's not too common, but there are other things we look at to just wonder if there are, other things at play that might be making it hard for the couple to get pregnant. But the two most important things are really the number of sperm and the movement of the sperm.
Sure. Well, maybe as you referenced, let's back up a little and sort of think about some of the causes of these abnormalities that you might find on the semen analysis.
I often talk to patients about those causes in buckets or categories. And so one bucket or category is hormonal. So we know that there are hormones that are important just in normal human biology to help make sperm and make sufficient numbers of sperm. The most relevant hormones are sort of testosterone, estradiol, and FSH, or follicular stimulating hormone. So a standard part of a male fertility evaluation is going to be checking for those and sometimes additional hormones, but those are the core ones we look at.
Do you find it surprising to men that you're talking about estrogen or estradiol in a man? Everybody knows that's a female hormone, but it's not nearly that simple.
Right. I mean, I think this is what's somewhat magical or awe-inspiring about the human body is men and women are very different in many ways, but they are often built from very similar components or parts, and so yes, men have testosterone and men have estrogen. Women have testosterone and women have estrogen in different proportions and serving somewhat different roles, but they both are important.
Yeah. So hormonal issues, problems with the pituitary gland, maybe problems with the thyroid gland, and testicular function from a hormone standpoint would be a category. What other types of problems are you encountering that cause issues on the semen analysis?
Yeah. So one other category that comes up, especially when a man has a very low sperm count, are genetic causes. So we know that there are we in science have identified certain genes, certain sets of genes that we know cause a man to have a very, very low sperm count or a zero sperm count. So if a man has a very low sperm count, there are certain genetic tests that we will look for. We will look for what's called a karyotype. That is simply counting the number and the alignment of the chromosomes. A typical man has 46 chromosomes, including one X and one Y, and abnormalities in just the number and alignment of chromosomes can be one of the things that can cause a man to have a very low sperm count. There's also a region of the Y chromosome that's known to be particularly important for making sperm, and we have testing available to look at that region of the Y chromosome. Now, admittedly, there's probably hundreds, maybe thousands of genes that are actually important for making a sperm. And although science has discovered a lot, we've not discovered them all. And so there are genes that we can test for, and unfortunately, genes we can't test for.
Yeah.
But that's part of the evaluation as well.
Now, when you encounter men, as you're describing, with very, very low count or no detectable sperm, are you likely to find a cause that you can put your finger on and say, this is it? Or is it more likely that you don't get a clear-cut answer?
Yeah, that's a good question. And I don't know that we have very strong data to give you an exact percentage of the time. But I would say there's a fair amount of the time where we can identify a specific cause. And admittedly, there's also a fair amount when we can't.
Sure.
Personally, I suspect that many of the times when a man has a normal hormones, normal genetic testing that we know how to test for, and we can talk about some of the other factors in a minute, but normal evaluation otherwise, I often think that his zero or very low sperm count is a result of some of those genes that we haven't discovered yet in medicine and science.
Sure.
Yeah, so it kind of happens in both ways, fortunately or unfortunately.
Yeah, and isn't that true across all branches of medicine? We're really good at what we know. We just don't know what we don't know.
Exactly right. Exactly.
Good.
Yeah, and so another big category we will often talk about is lifestyle factors.
Yeah.
And so here, regardless of the man's sperm count, I think it's an important opportunity to talk about lifestyle factors that we know can influence the number or the quality of the sperm. Both tobacco and nicotine are known to be bad for sperm. Obviously, tobacco has been around a very long time. It's very clear that cigarettes and cigarette smoking are bad for male fertility, and I'm sure you could speak expertly about the female side. And I think we're also learning that even just nicotine, there's a lot of products today that are not tobacco, but they do contain nicotine, the pouches, the vapes, and there's growing bodies of evidence to suggest that even just nicotine is not good for sperm. So I always counsel patients about that. THC, marijuana, most of the sort of good basic science laboratory style studies are pretty clearly show that THC, the active ingredient in marijuana, is bad for sperm. Admittedly, there have been some very large epidemiologic studies that look at, claim sort of administrative claims data or epidemiologic data and look at marijuana use and fertility. And frankly, it's a little less clear. However, those epidemiologic studies are often difficult to draw firm conclusions from because of all the other factors that come into play in studies like that. So I do counsel patients that THC is bad for sperm as well.
Sure. So I think I'm correct that casual marijuana use in Michigan is now legal.
Correct.
Do you think a correlation between increased usage maybe and decreasing sperm and men's health there?
That's a good question. I haven't seen good research or data behind that.
Yeah.
As a clinician that cares a lot about male fertility, it's one of the things that I worry about, is how much is it known among young men who are using marijuana regularly now? How much is it known by them, that it could impact their fertility? And if they knew that, would they change their decisions and their habits?
And along those lines, if a man is using and it has a detrimental effect, if he stops using, does that repair?
It does. The human body is pretty wonderful in that way. And so regardless of whether it's THC or tobacco or some of the other lifestyle factors we can talk about, it takes 3 months to make a sperm. So I always tell patients that, that if they stop whatever that influential factor is now, 3 to 4 months down the line, we should start to see improvements in some of the things that we can measure in the sperm count. We won't see it right away, of course. I think of it often. We're in Michigan. There's a lot of cars that are made in Michigan. I think of it a lot like a assembly line of a car factory. That I went to the Ford F-150 plant the other week with my family. It's a pretty amazing thing for any of your listeners that might want to come. But you see all these sort of trucks being made. If you change an element of the production line, the trucks that are past that point of the production aren't going to be any different. It's only those trucks that haven't made it yet to that start of the production line that you will start to see the impact of the change. And again, it's the same for sperm.
Yeah. What about alcohol? I get that question a lot. What's the data say about men and alcohol?
So 1 drink per day is perfectly fine. The data says that when men start having 2 or more drinks per day on average, that there is a link, an association with lower sperm quality and lower sperm number.
Interesting.
Getting pregnant is a stressful process often for the patients, at least that have made it to my office. It's, they would love to have been pregnant already and not needed to see me. I always tell patients that finding healthy ways to manage their stress is important. And I don't necessarily prescribe alcohol as a means for that. But if someone having 1 glass of wine or 1 beer at the end of the day is something that helps them, I think that's perfectly fine and not going to affect his fertility.
Yeah. But beyond that, it certainly could have a negative impact.
Yes, absolutely. So I advise patients just to stop it, an average of 1 a day.
Yeah. And, we couldn't talk about lifestyles, I guess, without talking about just sort of general health, exercise, diet, those things.
Absolutely. And so the simplest way I explain this is what's good for your body is going to be good for your sperm. And so sleep, exercise, healthy diet, healthy body weight, and healthy stress management. And so I think a lot of us think about how we can just be healthy for our bodies, and those things are going to be good for our sperm as well.
Yeah. You remind me, thinking of men as well as women, but fertility is a great litmus test of health. When we're at our most healthy, we are typically going to be at our best fertility rating, aren't we?
Absolutely. And there's been some really great research in the male fertility space showing that men with low sperm counts are at higher risks for cardiovascular disease, heart attacks, strokes, certain types of cancers. And so you do wonder, there's a link in there somewhere between your overall health and your fertility and the rest of your body as well.
Yeah.
Part of the reason why we think it's really important for men with abnormal sperm counts to see a urologist is not just so that we can help them with their fertility, but we can also identify if there's other parts of their health that their primary care doctor, if maybe they aren't connected as closely as they could or should be, that we can kind of make sure that they're taking care of the rest of themselves as well.
Yeah. You say that, I'm reminded of a patient that I sent you some time ago, and I believe you found a malignancy as part of the workup for the couple's fertility challenge, and you may have saved his life by looking.
Thankfully, that doesn't happen often, but it is a known risk factor that if a man has infertility issues, he is at a higher risk for things like testicular cancer. So one of the things that we always look at on our evaluations is the testicles, and are there any testicular masses or lumps that we need to investigate further? Absolutely. With exercise, I do want to mention that a moderate amount of exercise is good. There is research showing that extreme amounts of exercise lowers sperm counts. What defines extreme? It's a good question. I say marathon training, right? So doing this sort of 40, 50 miles a week that marathoners will do as they get close to their training, that is probably too much exercise, at least from a fertility standpoint.
Interesting. We'd be remiss if we didn't talk about hot tubs, right? We can't let that go.
Absolutely.
It's winter, the temperature is dropping, hot tubs are calling people's names. Give us some really good advice on hot tub usage.
Right. So the reason the testicles sit outside the body is the testicles want to be cooler than our core body temperature. And so things that dramatically raise the temperature in and around the testicles are not good for sperm. So saunas, hot tubs, steam rooms are a pretty intense level of heat that is not good for sperm. So I absolutely advise patients to avoid those things.
Yeah.
Showers are fine. Showers don't get quite as hot as any of those other mechanisms. So, try not to tell men they need to take cold showers in a Midwestern winter. That's just not fair. or fun. But saunas, hot tubs, steam rooms, those are really, really hot and should be avoided for men trying to conceive.
Yeah, and as you pointed out, there's this time problem. So you could stop today, but
Yeah,
it's going to be 90 days before things get better. So yeah, get busy.
get busy. Yeah, and then exercise and then body weight, right? So there is a link between higher body mass index and in particular higher waist circumference and lower sperm counts. Not an easy thing to change either. But again, when we think about that link between fertility and overall health, it's an opportunity to improve not just someone's chances of having a baby, but their own longevity and health overall.
Yeah, you remind me, I would have forgotten unless you said that like you, I'm bombarded now with questions about the GLP-1s and GLP-2s, the Ozempics and the tirzepatides and the Zepbounds and all of
Yeah.
I get the names mixed up.
Yeah.
But there's so much in social media about improving women's fertility for polycystic ovarian syndrome and other things. You mentioned weight loss. Is there a role for these medications in men who are obese and trying to improve their fertility?
I think on the benefits side, it's too early to tell. As you said, these are newer medicines. And I don't think we have a robust body of research yet proving
Sure.
that taking this will improve a man's fertility.
Mm.
I think from what we have seen so far, I think what I tell my patients is I do not think it's going to harm his fertility.
Sure.
Right. And so if patients are interested, men are interested in taking one of these GLP-1 medications, I have no concerns or objections from my side as a reproductive urologist. It's certainly going to help other parts of their health.
Right.
I don't think it's going to hurt their sperm, but it may help them. Time will tell.
Yeah. Interesting. It's funny. I often find that the men that are sitting in my office have never once thought about their overall health until they're sitting in my office. And suddenly now, when we're having this discussion, they have all these questions. Well, I should stop smoking. I should stay out of hot tubs. I should lose weight. And yes, all of those things that your mother would have told you, still sound advice, isn't it?
It is very much sound advice, yes. And I mean, I can certainly speak from my life. Like, becoming a father was a transformative event for me and my family and in my personal life, I mean. And I very much understand that for some men, this is maybe the first time they've either had to or wanted to really think seriously about that. I think it's one of the, what our duty as physicians at these moments in time is to help patients recognize that and help support them as they become more and more interested in that. It's sort of one of our duties.
Oh, yeah. So you mentioned earlier when you were talking about surgery and delicate and microsurgery things, what types of things are you encountering in your evaluation that are anatomical that might need, surgical intervention?
Right, and actually, great segue. That's actually the last category of things I always talk about with patients. So we talk about hormonal issues, genetic issues, lifestyle issues, and then anatomic issues. And what I mean by that is kind of the anatomy, like the actual structure of the penis, the testicles, the scrotum. You actually already mentioned for a patient of ours that we have both had the pleasure of taking care with, the importance of looking for, abnormal and dangerous anatomy, things like testicular masses. So that's one of the things we look at. One of the actually quite common problems with the anatomy is something called a varicocele. A varicocele is an enlargement of the veins in the scrotum. It is the scrotal equivalent of varicose veins that some people get in the back of their legs. Maybe they or their family members have had that before. Varicoceles are very common. They happen in about 15% of all men in the country. Now, not every man that has a varicocele is going to have a problem from that varicocele, but there is a subset of men who are having fertility issues that we think is likely from the varicocele that we will offer treatments to. There's two different ways we treat them. One of the ways is surgery, and that's sort of one of those microsurgical, delicate procedures that I mentioned earlier.
Yeah. What is that? What's that look like? And what I mean when I say that is the probability of improvement after varicocele repair.
Right. So the patients who have the clearest benefit from fixing a varicocele are patients where they've been trying to have a pregnancy for a year, or if their partner is 35 or older, at least 6 months.
Sure.
Where the man has a varicocele that the doctor can feel on physical examination, Ultrasounds actually can be useful to look at the scrotum, but sometimes they can be too sensitive. They actually can pick up
Oh,
small little varicoceles that frankly aren't clinically impactful. So if the man has been trying for a year, has a varicocele the doctor can feel on physical exam, and has an abnormal sperm count, a low number or a low movement of sperm. That's the population of men who benefits the most. In that group of men, about 60 to 70% of them have an improvement in their sperm count or sperm movement after surgery. Um, we talked earlier about the 3-month time frame. It's important for men and their partners to know that those improvements don't happen right away. So when I say 60 to 70%,
yeah.
that's a minimum of kind of 4 to 6 months after surgery, sometimes even longer.
Sure.
Right? So it takes time to get there, but 60 to 70% will have an improvement. One of the best studies that was done about this took about 150 couples. All of the men had a varicocele that you could feel on examination. All of them had female partners that were 35 or younger and healthy, and they randomized them. They effectively flipped a coin. And half the men had surgery, half the men didn't. In the men that had the surgery, they had about a 2 times higher chance
Oh, wow.
of having a pregnancy over the next 12 months compared to the men that did not have the surgery.
Wow. So varicocele repair is something you do as a reproductive urologist. Is it fair to say that general urologists also often do varicocele repair?
I think it'll depend on the urologist training.
Yeah.
In residency, most residency programs in the country today have a reproductive urologist that's one of their instructors, one of their faculty members.
Sure.
But there are some that don't. So there are some urologists that may not have the opportunity during residency to do much of that type of a surgery. That doesn't mean they can't learn it later, and many do learn it later. So
Yeah.
I think it depends on the individual urologist among the non-reproductive set. In the reproductive urology set, I think we are all well trained and kind of specialize in that as one of our core procedures.
Yeah. And unfortunately, there's a real shortage of you and people like you. I mean, here in the Midwest, there's just not a lot of options. I mean, I think men are going to be traveling. Now, maybe post-COVID, we've learned that we can do more with remote, like you and I are doing now, but it's still, there's too few resources of great people like you, so that can be a real challenge, can it?
It is, yes, absolutely. That is a challenge. It's one of the things that I think we as a field of reproductive urologists are working to try and solve is how do we make sure that everyone has access to the care that they need. Telemedicine is a great intervention that helps, in the state of Michigan, you can live 10 to 12 hours from Ann Arbor and still be in the state of Michigan, which I always find a little astounding. And so for those men from the Upper Peninsula, we do a lot of telemedicine to try and give them care without having long drives for them. But nevertheless, sometimes it does require a drive. We are training more and more reproductive urologists each year to try and, again, expand the access for patients. But, Chris, you're right. It is one of the problems right now. It can be hard to find a reproductive urologist. There are non-fellowship trained urologists who are actually very good at fertility care as well.
Sure.
And so for men who may not have access to a reproductive urologist, it is perfectly reasonable to see a urologist from their community. And I think it's a fair question to ask, how comfortable and how much experience does that urologist have with fertility care? And if the urologist has good experience and comfort, it is perfectly reasonable for them to get their care from a urologist that maybe didn't do a fellowship.
Yeah, I could see that conversation being even more critically important if there's a surgery being planned.
Yes.
I know that's certainly true on my side of the equation. And it just came into my head, we'd be remiss, I guess, if we didn't talk when we're talking about surgery, vasectomy reversals. I don't know. I would say whatever I see in my office is going to be a day and a half after it happened on social media. That's what everybody is asking me. But I certainly have been flooded lately with, men that have had a vasectomy and they want it reversed, and they're trying to get good information on and how to even begin approaching that topic. How do you advise couples like that?
Yeah, I think it's really good for a couple like that to meet with both a reproductive urologist or a urologist that is, again, well-versed in that surgery approach, and for them to meet with a female fertility specialist, because that couple has several options.
Sure.
I always tell that couple that, there's generally 4 options for having a bigger family or building a family after a vasectomy. 2 options that involve the man's sperm, 2 that don't involve the man's sperm. the two that don't involve the man's sperm being adoption or using donor sperm for an insemination. And then the two that do involve a man's sperm being a vasectomy reversal and the second option being a sperm biopsy, a sperm retrieval procedure for the man, and in vitro fertilization or IVF for the woman.
Sure. Yeah. Do you encounter or do you perform vasectomy reversals often? Or is that something that ebbs and flows in popularity, you might say?
No, I do, and I perform them pretty consistently. I had a patient the other day that was asking me a question like that. I think I've probably done well over 100 in my career, which is a lot actually for a procedure that nationally is not done very often.
Sure.
Yes, it is one of the procedures that I trained in. It's frankly probably one of my favorite surgeries to do because of the delicacy and precision of it. And frankly, it's also one of my favorites because of it can often be quite successful. And when you get that follow-up phone call several months later that someone's pregnant, it's a really happy moment to know that you were able to help a man and his partner, build their family in that way.
Are there other things that you ask that will help you predict who is a good candidate maybe for a vasectomy reversal and what increases the likelihood that it will be successful?
Yeah, that's a great question. And men will ask me that a lot as well. And I think this is also where it's really important where people are getting their information from, because I've had a lot of patients that get, information, I guess, that's different than the information that I give them. That's probably a good way for me to put it, I'd say. Things that affect the success of the vasectomy reversal are largely the things that affect which technique we are able to do to reconnect the plumbing, so to speak. Ideally, we reconnect. So sperm are made in the testicle. Sperm then move from the testicle into a gland called the epididymis on the back of the testicle. That epididymis is kind of like a storage storage tank for sperm. Before the sperm then move through the vas deferens, which is the tube that take the sperm from the epididymis to the prostate and out the penis. The vas deferens, of course, is what gets cut with a vasectomy in the first place. Ideally, we hope to be able to sew the vas deferens back to itself in a vasectomy reversal surgery. That type of vas deferens to vas deferens connection is much more reliable. It's a really strong connection. And if we're able to do that for both his right and left testicle, there's about a 90 to 95% chance that he has sperm in his ejaculate after he's finished healing from the surgery.
Wow, that's high. That's terrific.
There's a really good chance. Now, the other type of connection is when we have to sew the vas deferens directly to the epididymis. That occurs because sometimes, over time, a man can actually develop a secondary blockage in his epididymis. Think of it as like a blockage upstream from where the vas deferens was cut in the vasectomy. When men develop that secondary blockage, we have to bypass the blockage by sewing the vas deferens to the epididymis. Things that increase his likelihood of developing that blockage are predominantly time. So if it's been 10 years roughly or more, there's a higher chance that man has developed a secondary blockage. But again, the human body will surprise you often. There are times that I've done vasectomy reversals on men 26 years out from his vasectomy where he did not have a blockage in the epididymis, and I could go to that vas deferens to vas deferens connection. And unfortunately, I've had the rare patient who's maybe only 4 or 5 years out from his vasectomy where he has already developed that blockage, and we have to move on to plan B. It's one of the things that we always look for during the surgeries. We look to be sure that all the plumbing is open before we start reconnecting things. And I think it's important that patients considering this option talk to a surgeon that is ready and prepared to perform either of those two techniques.
Right.
Because you don't really know until you're in the operating room. But you can be pretty good at predicting it, but you need to be prepared for both situations.
But I mean, your message is one of hope. It sounds like that. Depending on the specifics, obviously, but there's great hope. It would sound, especially if you could do the end-to-end, that fertility could be restored.
That's right. And I think the other half of the equation, though, is also I always have a conversation about the female partner.
Yeah.
And this is where I want to make sure the female partner is seeing an expert like you, because we want to know that she has a decent chance of getting pregnant, assuming we can get the sperm flowing through again. You could imagine a situation where something has happened in the female partner's life and her fallopian tubes are blocked.
Yeah.
Well, we could help the man have all the sperm in the world, but they're still going to need have other ways to get pregnant. And so, much like we talked at the very beginning about, it's important for a couple seeing you to think about the man. I think it's also important for a couple thinking about a vasectomy reversal to consider the woman and her health.
Yeah, that's a great point. I find a lot of times I'm talking to couples and there's multifactorial things, as usually is the case, and they're getting the cart ahead of the horse sometimes. They'll want to work hard on the semen analysis parameters, maybe even to the point of surgery, when we haven't done anything with ovulation and pelvic health, and we may not even be successful on that end. But that's a great point. Yeah, that's worth remembering.
And that's part of what I really enjoy about this field of medicine is, frankly, getting to partner with people like you. I think infertility is one of the only parts of medicine that I've been able to ever think of that involves more than one person. Most everything else is a single person has diabetes or a single person has heart disease, but it's really a couple that has infertility. And so I enjoy being able to work with folks like you who can really help on the female side and I help on the male side. And it's about collaborative care to help this couple with their goals.
Yeah, there's no email quite so exciting as that one that comes with a picture of a baby.
Yes, absolutely. Absolutely.
I get a lot of questions, or at least I've been seeing a lot of questions on social media recently, it feels like, about sperm genetics and fragmentation testing and some of the higher end testing. Could you kind of speak to that globally and direct our viewers a little bit on that topic?
Yeah, happy to. So we are very good at counting sperm. And what I mean by that is we're very good at putting a sample of sperm under a microscope and looking through a microscope and judging how many sperm are there, how many are moving, and what does their shape look good or not. We're very good at that.
Yeah.
Admittedly, we are limited in our ability to evaluate the quality of the sperm. Most of our parents probably told us don't judge a book by its cover. We do a lot of that in reproductive medicine. We are judging the sperm by how they look on the outside. And admittedly, we have a limited number of tests to look at the inside of the sperm, the quality of the DNA. But frankly, for many patients, that's really not necessary. But there are a subset of patients who benefit from doing some of this more advanced testing like you described. One of those advanced tests is called a DNA fragmentation test. As a reminder to your viewers, DNA is the genetic material that's packaged inside of the head of the sperm. The DNA are supposed to be in nice, continuous strands of genetic information. And for a variety of reasons, sometimes those strands can be broken or fragmented. Okay. And if men have high levels of DNA fragmentation, high levels of breakages to those DNA strands in their sperm, a couple different things can show up. They can be at a higher risk for miscarriages. If they go through IVF, it can be a higher risk for lower fertilization of the sperm or poor development of embryos through those first 5 days of the IVF process in the lab. And so when couples have had 2 or more miscarriages or had an IVF outcome that was kind of unexpected, one of the advanced tests that we offer them is a DNA fragmentation test. It's a test done on a sample of sperm, just like the regular sperm counts they've already experienced. But again, instead of counting the number of sperm, laboratories do investigations of the DNA strands.
Yeah. So I guess the obvious follow-up, you do the test, you find that this man has a high percentage of DNA fragmentation. What can you offer him?
So great question. This is where I think the rest of those evaluation that we spoke about comes into play.
Yeah.
If a man has a varicocele, fixing the varicocele has been shown pretty clearly to improve or lower the levels of DNA fragmentation in the sperm.
Sure.
If a man has any of those lifestyle exposures that we worried about, tobacco, nicotine, marijuana, heat, and all of those sources that you mentioned, Chris, abstaining or removing those is one of the things that men can do to lower their DNA fragmentation levels. There's some newer research that suggests that actually frequent ejaculation can lower the DNA fragmentation levels, often thinking about that as sort of younger, fresher sperm with each ejaculation, so to speak. And then in the IVF process, there's really kind of 2 things that can be done. There's a sperm filter that can be used to sort of filter sperm, and the sperm that come through the far side of that filter tend to have lower DNA fragmentation levels to then be used to fertilize the eggs. And sort of as frankly a last resort, because it's invasive, we actually can do a testicular biopsy and get sperm directly from the testicle, because those sperm from the testicle almost universally have lower DNA fragmentation levels than ejaculated sperm. But again, that's an invasive procedure that we do, but we really try and reserve it for those cases where it's clearly kind of necessary.
Yeah. Well, that's a lot of information.
Yeah.
Thank you.
Sorry if it was dumping too much.
No,
but yes.
I mean, even then, you're just giving us a little window into the vast area of male fertility. If nothing else, I hope viewers get a sense of just that. It's vast. It's not just a sperm count. There's so much more going on.
No, go ahead. I was going to say, I think this connects back to what you were talking about earlier about lifestyle, right? Again, we can count the number, but admittedly, we're limited in our quality evaluations. And this is where I think a man's overall health, his exercise, his diet, his body weight, sleep, those things, I think are ways that try and improve the quality of the sperm, not just the number.
Do you have an opinion on supplements? So we have a man who has maybe a marginal analysis, maybe diminished motility or something. They're bombarded with advice on supplements. How do you navigate those complex waters?
Sure. And so I'll tell you what I tell them, Chris, which is that there's never been a supplement that has been proven to improve the chances of having a baby. There have been some supplements here or there that have, on a study, found that some single number on a sperm test gets better, or some single thing gets, some little element of maybe the intermediate step of a sperm count gets better, but none have ever really been shown to improve the odds of a baby. Actually, in fact, the National Institutes of Health funded a very big trial called the MOXIE trial several years ago, and about 3 or 4 years ago, they published the results and said it does not improve. The supplements that they looked at did not improve the chances of a couple having a baby. Now, that being said, I don't think the supplements are going to be harmful either. And I certainly meet people, you probably have met folks as well, who feel very compelled to include supplements in their regimen. And I have no objections to that. Again, as long as it doesn't cost them too much money and as long as it doesn't give them side effects or upset stomach, men are, I think, are welcome to take those supplements, but it is not something that I push or encourage among my patients. Again, I think a healthy diet should be giving them all the nutrition they need, with one exception. I think it's very important that men avoid supplements that claim to boost testosterone.
That's a great point. Yeah.
Not all, some of those kind of hormone boosters, testosterone boosters, et cetera, pro-hormones, actually have been found to have testosterone or hormonally active chemicals within them that work counter to their fertility goals. I guess we haven't had a chance yet to talk about another important education for your viewers, which is that testosterone medications, creams, shots, pills, nasal sprays, any of those sort of external testosterone products actually lower a man's sperm production.
It's a bit counterintuitive, though, but yeah, absolutely.
Totally counterintuitive.
Yeah.
And to be frank, even among urologists, there was a survey done several years ago, and a small percentage, but there was a percentage of urologists in this setting that were suggesting that men take testosterone. And so I'm not trying to throw urologists under the bus. I'm just trying to give patients a little bit of grace to say it is very understandable why that might be counterintuitive, even among medical professionals.
Yeah.
But yes, it's important, very important for your viewers to know both prescriptions and supplements that claim to boost hormone levels are something they should avoid while trying to conceive.
Yeah, I've often thought the bias maybe in supplements help men and pregnancy rates go up is I sort of think if there's a man who's willing to take the supplements, he might be willing to change his other lifestyle things as well. And maybe that's the confounding sort of success. But I'm with you. I don't think it's detrimental outside of these testosterone problems. But it's also hard to sort of prescribe that, so to speak, as the answer.
It is. But I very much understand where patients are coming from. Again, I see it. I see it in my patients. I'm sure you see it in yours. There is such a strong hunger and drive to build their families that I think a lot of patients understandably feel desperate. They're kind of grasping for anything and everything that they think they can do to help stack the deck in their favor. And so I understand the desire. I just hope to try and give them some advice and maybe a little bit of permission to save a little bit of money if, and spend it elsewhere if they need to. And yeah.
You remind me, I try to always remind couples that you're incredibly vulnerable. The longer you've been in this journey, the more vulnerable you can become. And particularly now with social media, here we are doing it. Hopefully we're doing it for good. But it's such an avenue to attack their vulnerabilities that because there's just this one more thing syndrome. If I just took that supplement, if I just did that, everything would be fine. Because it is a hard journey for couples.
It is. And I really like the way you phrase that, Chris. I've not phrased it in that way, but I might take that from you, if I may borrow that phrase from you. Because one of the things I try and say to them is like, try and remind them to sometimes just take a week off, and make sure that they are taking care of themselves.
Yeah.
I appreciate many of my patients' commitments to do every single thing, quote unquote, right. But I think sometimes that drive, that pressure that people understandably put on themselves, that can be really hard and affect the rest of their lives. And so, there's some really great support groups that are out there. You probably mentioned this to your patients as well. And I try and encourage patients to find a friendly ear to talk to just about how hard it can be, so that they can maybe take a little bit of pressure off of themselves.
Yeah. Well, Jim, as we wrap up, I know listeners, they're going to be desperate to talk to you after this episode. So how does a family get in touch with you or someone like you?
Sure.
We have patients from all over the Midwest. I mean, how do they take that step if they think, or maybe their family physician or their obstetrician gynecologist is trying to help them? How do they take that step and find a reproductive urologist like you to start getting answers?
So there's a great professional society. It's called the Society for the Study of Male Reproduction. It's a mouthful. The acronym is SSMR, and there's actually a directory on there of members of our urology community who are part of that society. And I think, the folks that really choose to spend their time and pay a small annual dues and be part of that society is a marker of urologists that are really committed to this type of reproductive care. I would encourage patients from around the country to go to that SSMR, Society for the Study of Male Reproductive directory, and look up a physician.
Oh, nice.
If they're in Michigan or close to Michigan, of course, I'd be happy to see them. I work out of the University of Michigan. We have a Center for Reproductive Medicine. So our phone number for patients interested in referrals is 734-936-7030. I also want your viewers to know if they're interested in being cared for, I have two wonderful partners who are also specialists in reproductive urology. And so I'd be happy to see them. I've got other folks here that are experts in this care as well, that might be able to also just help them see them on a quicker schedule. But around the country, that Society for the Study of Male Reproduction, I think, is a great resource.
Oh, that's perfect. Well, I can't thank you enough for spending, this amount of time with me and with our viewers. It's been incredibly educational. I really appreciate it. I hope we can get you back to talk about other topics sometime.
I'd be happy to, Chris. Thank you so much for inviting me. This was a lot of fun. And thank you for the efforts you're doing to help share kind of good information to all of those out there in the world that are interested in it. So I'm grateful for the efforts you put into this. And again, thank you for including me.
Excellent. Thanks so much.
Take care.
Well, I hope you've enjoyed that discussion with Dr. Jim Dupree from the University of Michigan. I know I certainly have. I hope this has helped you and your spouse, if you're listening on behalf of your spouse. I hope it's helped you get a sense of how absolutely important male fertility is in the equation. I like to tell couples every time that we're talking, there's 3 categories of questions that we're looking at when we're assessing fertility. Category 1, is there a sperm? All things male. Category 2, is there an egg? And category 3, can sperm and egg get together? So the male evaluation is at least 1/3 of the evaluation. And so if we skip that, we're doing ourselves and you a disservice. And Jim talked about the motility component. Can sperm and egg get together? For them to get together, the sperm have to be motile. So it's absolutely critical that we not overlook the male component to the fertility question. So I hope, as I said, I hope that's been helpful. Thank you for listening. Thank you for joining us. I'd love to know your questions. on this topic. If you'll put them in the comments below, I'll do my best to answer every one of them. I'd also love to know topics that you'd love to know more about for future episodes. So thanks again for joining us, and I'll be back soon with another episode of All Things Women's Health.